evening, everyone. I'll be presenting on a postbone contracture of breast and anterior chest wall. This is a 20-year-old female who came with complaints of inability to abduct her left arm and scarring of the chest wall since 2 months. On inquiry, the patient sustained thermal burns 6 months ago when the patient accidentally caught fire in her dress at her home, and the fire was doused immediately with water, and the patient was taken to the hospital and treated with IV fluids and regular dressings. The patient was discharged with dressings and no surgery was performed at the time of initial admission, and was discharged at the end of around 2 to 3 weeks, and eventually all wounds healed with dressings only over a period of 2 months. 3 months after discharge,
Do not get what you want, you get sorrow. Somebody else gets what you want.
Can these other participants mute their phone so that Dr. Amrita can continue?
shall I continue, sir? Yes, sir. Shall I continue, sir? I'm not sure. I'm audible, do you know, sir?
Yeah, you are. Please carry on.
Yes, sir. Yes, sir. Humans the right left shoulder region, and the deformity progressed, increasing. The patient is presently unable to completely abduct her arm. This is the 20 years female which I have been describing. She is a moderately built woman with no other comorbidities. And the scar, which I've mentioned already, is covering the chest, extending clearly from the sternal notch to the xiphoid and then from right to left side, from the right anterior axillary fold to the lateral chest wall on the left side, crossing the anterior axillary fold, lateral chest wall to the posteriorly, and the left shoulder joint is also scarred, the superior shoulder region, and the left axillary contracture, which is restricting the left arm and extending up to the mid-arm level. What I could see from the picture, because of the axillary contraction, the left breast is distorted and pulled up. There is distortion and plastering of both bilateral breasts, but the distortion of the left breast is more than the right. The NAC axilla. The right NAC seems to be in the normal anatomical position.
Dr. Amrita, not sure about your connection. I can't really hear very much. Can others listen? Dr. Radhakrishnan, Dr. Bhavi?
No, it is a bit unclear.
I missed a chunk of your conversation. Is your connection okay?
Sorry. Is it now okay, sir?
Much better.
Can you restart from your assessment of the axilla, because we lost a chunk of your discussion. Sorry.
Yes, sir. This is a moderately built patient, which I've been describing, with no comorbidities. The burn scar covers the entire anterior chest wall, extending superiorly from the sternal notch inferiorly to the xiphoid sternum, and extending to the from right side. It involves both breasts, from the anterior axillary line on the right side to extending to the lateral chest wall on the left side and posteriorly. It involves both the breasts, sparing the NAC. The right axilla, left axilla is involved, and the right axilla is, the left axilla is contracted, and the scar is extending up to the mid arm level and restricting the shoulder movements. The left NAC complex is pulled towards the left axilla, and it's pulled superiorly towards the left axilla. The right axilla is not pulled and is in the normal anastomosis at the mid-arm level. This is the posterior extent of the scar. These photos were the photos which were shared with me. So it is a class 4 axillary contracture on the left side with distortion of both breasts, left breast more than the right breast, bilateral NAC being spared. There is no other scar in the body, including both thighs. The diagnosis would be it's a post-bone contracture deformity of diffuse nature over the anterior chest wall, including breast and over the left axilla of 3 months duration with restriction of shoulder movements. Problems which need to be addressed are the left axillary contracture and the bilateral breast. Rather than the bilateral breast, it is the left breast which needs and the left axillary contracture. Once the patient the routine blood investigation, since the patient has no comorbidities, for anesthetic clearance, I would like and to see the assessment and hemoglobin of the patient. Basic investigations will be done, and after anesthetic consent, clearance and consent, I would like to plan for the surgery. The plan for my surgery would be a staged one. The first, I would like to address the shoulder and the axilla. For the shoulder and the axilla, I would like to plan an incisional release followed by skin grafting with an aeroplane splint. The incisions would start from here, like a U-shaped incision, cutting across like this anteriorly and extending posteriorly like that. So while giving the incisions, the after incising, the sections will be done so that the arm will be abducted on table up to 90 to 120-degree abduction will be tried, and whenever needed, the tension scars will be released by back cuts and fishtailing whenever necessary will be done, and we will result with a resultant defect which will be measured, and accordingly skin grafts will be taken and skin grafting will be done. So with this type of release, we would expect the left breast to drop down so that the pulling is relieved, and the important should be done. The postoperative care will be from once the graft is placed on table, vac will be placed and splinting is done. The vac will be discontinued after the and regular dressings will be done. And whenever there is any graft loss, regrafting will be done. All wounds healed by primary intention. If everything is well and at the end of 2 to 3 weeks, if the wounds are dry, I would discontinue splinting and continue with
Amruta, we are not able to hear you clearly actually.
What to do? The internet is all right. I could hear you all very clearly.
Okay.
It's very hard.
Yeah.
It is okay.
Can you actually stop projection and then just use the audio only? Please
Yeah.
stop projection. We can ask Shravan to actually do your projection for you.
Are there any more pictures for this, or that's the only one? Isn't it?
What's up?
There are no more
You, sir?
to
Sorry.
project, isn't it?
No, sir, that's all, sir. Just two more, sir. For the rest, what I expected mostly it will get corrected with the shoulder correction only, with the axillary correction. If at all something is required as a second stage, an incision over the IMF and I just have
I think we'll probably try what Radhakrishnan mentioned. Maybe you can close the video and try the audio alone, see whether we can hear you.
yes,
Because I'm
yes,
sorry,
sir.
again,
Yes, sir. This
missed
is
a
the
large chunk
last
of the
slide.
discussion.
It's okay, sir. Thank you, sir. I'll just stop my projections.
Shravan, can you just project in the meanwhile?
Dr. Bove, we can possibly continue the discussion with Amrita while you're
Yes,
waiting, maybe.
yes, yes. Uh,
Yes, sir.
do you have any other views of this patient? Okay, huh. And what about the donor
No,
area
ma'am.
for the skin? Okay.
Donor area I was given only two pictures. I hope
Okay.
both eyes are free so that I could take graph from both eyes.
Hmm. So when you mark your incision, what will you mark before marking your incision on the patient? What do you have
The
to
bony
protect?
landmarks.
Yes, bony landmarks have to be marked so that your incision does not lie on any one of them. And this is quite a bad adduction contracture. So what complications would you expect in the release?
The raw area will be more,
Yes,
and there will be exposure of neurovascular.
yes,
Yes, ma'am.
yeah. Uh,
Dr. Amrita,
hmm,
uh,
Yes, ma'am. Yes, sir.
I think one of the, I agree that whatever we do, it's going to be a difficult problem.
hmm,
Whether you release the contracture, skin grafting, there are highly likely you're going to have further contractures, ongoing contractures across the axilla. I thought Dr. Radhakrishnan wanted us to focus on the breast
breast,
reconstruction part of it
yes.
mainly. I agree
Yes,
that
ma'am.
axilla needs to be released for us to have a better outline of the breast contour before reconstructing.
Yes, sir.
Can we request the previous picture, the front picture of this patient, please? Yeah, thank you. So let's, for discussion's sake, assuming that the axilla is released now, can we focus on options of breast
I could not hear,
reconstruction?
sir.
This lady, please. Amrita?
Yes, yes, sir.
Sorry, I'm still not able
When
to
I
hear
did,
you clearly. Can you hear us?
yes, sir. I could hear.
Not a lot better, I'm afraid. Dr. Radhakrishnan, anything else can be done to help her in a way?
I think we might not be able to proceed because it's a bandwidth issue. So when that is there, it is quite difficult.
Sure, sure.
Yeah, I think if you can just actually put your thoughts on how you would proceed to go ahead with this, I think then we will call it a day for this particular
Yeah.
spotter.
Yeah. Dr. Bove, please, I'll follow you.
Actually, after release of the axilla, we will have to reassess uh, and see where the contracture is. Uh, uh, I would like to definitely go for initial skin grafting and then followed by lipofilling as required. We may have to go for repeated sessions because the she is just a child and breast is growing. Uh, according to the growth, we may have to stage. We will also have to address the sympmastia once the breasts grow completely, and we will require a management of the removal of the atrophic skin there and a skin graft.
I agree for most part in that. Was she a 20-year-old young woman to start with?
Was she?
No, so I was not given the age. I
Ah,
asked
then
for
I
the age
didn't hear.
specifically. Uh,
Okay.
yeah,
No, I mean, if it's a child,
maybe,
definitely, yes. She is going to need multiple procedures to help with her staged increase in her breast growth. So if she's in her early teens and she still has her physical growth in front of her, focus then may be to release the skin tightness,
Yes.
just to allow the maybe the breast diameter, the breast perimeter alone. It's a good thing that she has a nipple areola complex preserved for most part.
yes,
I agree, not fully, but for most part. She
okay.
will have to understand how much that breast development will be affected by the skin envelope being burnt. So it's very difficult for her to get a breast fullness, breast mound. Uh, but we have to allow her natural physical growth to see how much of that breast tissue she's going to gain by herself. To help, maybe in some cases, one of the discussion will be to just mark the breast template alone and then replace the burnt skin with some dermal replacement like Integra. We may use that just to free up that skin to stretch a bit better. I know the intention is not to create a whole of the chest skin to be replaced, but just around the breast mound alone, if we release the burn scar, we may use a dermal replacement under skin graft, which will be a little bit more pliable, and therefore there may be a better softness for it to become more projecting as the breast grows. Also, this may be a first step necessary for future placement of either a subpectoral tissue expander and slowly, gradually stretch the skin in a way that you can develop and help her to have a breast mound developed in time. Clearly, through her teens, the focus will be to allow the skin to mature and expand. And you're right, fat transfer will be a good idea to soften the burnt skin, where judiciously used along with tissue expander, maybe it'll help to free up the skin to become more open, more pliable. And maybe towards the end of her teens, maybe 18, 19, when her natural breast development is complete, then we can look at whether we need an additional implant in the area where we used a tissue expander to provide a volume. But my worry for this girl is that the skin will be the limiting factor.
Yes.
It will not allow to stretch any further. So we need to help the skin to soften by a combination of occasional release of the burn scar, maybe Integra, maybe a fat transfer to do that. You could consider doing a major microvascular reconstructions. However, a large area of skin bilaterally in a slim girl like her, I don't think you will have enough donor sites to provide that in the abdomen or in the gluteal area. So we have to consider most options locally with kind of combination of tissue expansion and fat transfer. That's my view. Dr. Radhakrishnan, any suggestions, Dr. Bowie? Anything else to that?
This is an extremely difficult case, actually.
Very
In the growing phase, when you have a burns like this, devastating burns like this, it's extremely difficult. Now the issue is like you said, putting Integra and the graft would be excellent. But the problem is, how are we going to do it? Are we going to do it at the superior pole or the inferior pole? Are we going to aim to actually excise the entire amount of scar in multiple sittings? Those are the questions that I think if you can just clarify, it would be better.
Sure.
Dr. Srinivasan.
Sure. See, I don't have the picture of this girl below the abdominal area, I suspect her inframammary fold is preserved. Although the skin is burnt, the fold is there. Um, I will probably start looking at the upper part, medial part of the breast, where mostly you will find the tightness, particularly in relation to the sternal area. In the inframammary fold area, when we come to put an implant, that itself may expand the skin a little bit more. So my main focus will be the medial part, and the superior part will be the crescent, kind of a half crescent of that area of the breast surrounding the nipple areola complex. I will probably replace it as an aesthetic unit in one sitting with an Integra and a skin graft in first stage. Depending on the availability of the material and the safety of doing that, I may do bilaterally at the same time. And then depending on how that changes, if other areas like inferior part, the other half of the circumference, if that needs addressing, that may be a second stage of the operation. The area along the lateral part, axillary part, and then coming towards the inframammary will be my second stage. First stage will be the superior pole, and the parasternal area will be my main area. So that's the cleavage area, so-called cleavage area, where the woman will look at, and any clothes that she wear, that's the what visible area. So my focus will be to replace that first with a healthier dermal substitute and a skin graft.
Thank you, Dr. Srinivasan. And also probably we could utilize a small amount of skin that is available on the right infraclavicular area, probably to expand it and slowly get it at least towards the center, so that when she's wearing a dress, that exposed part would not have any scars on that.
Correct.
Yeah.
Correct.
Dr.